correct and everything, but hopefully you guys can hear me, and the sound's coming through and the video's coming through and all of that. I'm going to switch over to another screen here. So hopefully you can see my slide presentation as well as my little face in the little corner. If you're watching, just send me a note and let me know that you can see. So I see a couple of notes. Hello from Mary and from Priyanka. And so I'm excited to see that it appears to be working. So I did this lecture about a week ago as a part of a live live lecture night that we had at the Animal Emergency Center in Moorabbin. And just to reiterate that it appears to be working. Just to reiterate that we do have specialist surgery services running out of the Animal Emergency Center in Moorabbin, if you weren't aware of that. Good for you to know. So full service specialty surgery with myself and Dr. Malcolm Jack in Moorabbin. So we'll go ahead and get started. Let's see here. So first thing I would like to do is start with a little survey. And the question that I have is, of the procedures that I have listed here, which ones are you doing? So if you want to put in the chat and let me know which of these surgeries you are doing, or which of these procedures you are doing. Are you grading your brachycephalic airway syndromes before you take into surgery? And that means grading the before and after moderate exercise. Those of you that are doing brachycephalic airway surgery, are you doing stenotic nares? And if you are, I've got some hints that will help you with that, and how to get a better outcome with that. Are you doing soft palates? And if you're doing soft palates, we've got a couple of hints that will help you with that. And are you doing laryngeal saccules? And my feeling is that if you're doing brachycephalic airway surgery in dogs and the saccules are out, you really need to trim them out, because I'm a believer that really can significantly impact the outcome. There are some people that don't believe in doing the laryngeal saccules and say that if they're averted when you resolve the obstruction farther up, like the stenotic nares and the soft palate, that the saccules will regress. I'm not a believer in that. I believe that if they're enlarged and sticking out, they really should be resected. So moving on. So just as a review, brachycephalic obstructive airway syndrome is a constellation of abnormalities in short-nosed dogs. And what's happened is that through breeding, we've taken like 40 centimeters of soft tissue and compacted it on 15 centimeters of skull, which means that you just have like an accordion. You have extra folds of tissue all the way down along the track, and so that's why we have the issues with obstruction. So clinical signs that we see would be stertorous breathing, exercise intolerance, respiratory distress, and also gastrointestinal issues. And understanding those gastrointestinal issues can help us understand a little bit better what is happening with brachycephalic airway disease. There are several anatomic abnormalities, and it's important to note which ones are primary and which ones are secondary. And again, because if they're secondary, maybe we can avoid them by fixing the obstruction farther up before those secondary changes have time to develop. So stenotic nares, which is a primary issue, elongated soft palate, which is a primary issue, laryngeal collapse we tend to think of as a secondary issue, tracheal stenosis is a primary issue, and then gastroesophageal reflux is a secondary issue. So as far as treatment is concerned, when I was growing up, so when I was being trained as a resident, traditionally we just did surgery to relieve the obstruction. So we would resolve the stenotic nares, we would trim the soft palate, and then trim the saccules out, and that's pretty much all we did at the time. But now there's an increasing emphasis on objective assessment and and medical management. So objective assessment beforehand to try to predict what kind of outcome we're going to get, and then medical management, which is also going to help with our outcome. There's a question here: any tip or equipment you'd suggest for laryngeal saccules? Found them too slippery to be held. So that's a good question. One thing that I find really helpful is DeBakey forceps. So DeBakeys are actually a cardiovascular forceps. You can get them probably for around $60 to $70. You can get really cheap ones on eBay for about $10 or $11, but they because they have a combination of vertical and horizontal striations, they really grab onto those saccules nicely. The other thing you could do is try to grab on with an Alice tissue forceps. I have also used a long rongeur, which actually is almost like an alligator forceps, but instead of the alligator forceps at the end, they have a rongeur at the end, and those seem to grip on really well as well. Again, regarding treatment, we need to remember that treatment is not curative in these dogs. We're not going to turn these guys into athletes. We're just going to make them breathe a little bit better and be able to do normal activities like go to the dog park, and the owners not have to panic when they're taking them out on a hot day or when they get overly excited. And also remember that it does require lifelong management of gastroesophageal reflux, also management of weight. So we need to make sure that we keep these dogs at a reasonable weight rather than letting them get overweight. So moving forward, so our objectives today are to review the changes in BOAS treatment that have happened in the last 5 years. So again, we used to do just surgery on these guys, but now there's a lot more to looking at things like grading before and after surgery, as well as medical management, either instead of surgery or in addition to surgery. So we've already reviewed the components of BOAS surgery, but we're going to review them in more detail. We're going to look at the diagnostic workup and what we normally do in every case versus what we do in selective cases. We're going to talk about a grading scheme, which is for clinical signs of BOAS, and that's going to help predict the outcome with surgery and the risk of complications. And we're going to look at the BRISC score, which is the Brachycephalic Risk Score for predicting complications that we might have with this surgery. We're going to look at medical management instead of or in addition to surgery. We're going to look at anesthetic and perioperative care, and then we've maybe got some little tricks or hints that might be helpful of stricture formation when you use cautery on anything. So, for example, I would never use electric cautery on stenotic nares because I have seen somebody do that and the nares stenosed down and it was basically unmanageable. That could not be resolved even with repeated surgeries. So, starting with the nasal issues, remember that stenotic nares or narrowed nostrils are a primary issue. So the dogs are born with these. Aberrant caudal turbinates are also a primary problem, and this is something that's being more and more recognized in brachycephalic dogs. If you look at a normal dolichocephalic dog, you've just got such a nice airway coming through here where they can breathe, whereas brachycephalics have a lot of aberrant or abnormal turbinates which can fill the caudal nasal passages. So in dogs that you do conventional surgery on and they still don't seem to have a very favorable outcome, then potentially managing these aberrant turbinates may be of some benefit. Okay, next issue is tonsils, and I haven't mentioned tonsils previously on this live stream, but tonsils can be enlarged as a secondary problem. What causes the tonsils to become enlarged? You have chronic airway obstruction, and that means that the tonsils are being sucked into the airway. You have tissue prolapse and edema and congestion and hypertrophy because of the suction against these tonsils as they're being pulled into the airway. You can have secondary inflammation due to turbulent airflow, and you can also have lymphoid reactivity due to regurgitation, aspiration, or bacterial overgrowth. And all of these collectively can cause enlargements of the tonsils, and in some patients, these tonsils can contribute to airway obstruction. All right, soft palate. So soft palate can be elongated and it can be thickened. So when we look at the soft palate here, this is the hard palate here, and then the soft palate is back there. What can happen is that the soft palate can drop back into the rima glottis and actually act like a cork and obstruct that airway. So I'm just going to see if I can do network bonding because I understand that we are having some issues with sound cutting off. Network, if the issues have stopped. It doesn't look like that's going to fix anything. Yeah, it may be some benefit. Can you let me know if you are having, or if the issues with the sound have improved or not? The other thing is that I am doing a live, I'm doing a very high quality recording of this entire video, and I will try to upload the raw video, which means that you'll have higher resolution and you'll also have better audio. So again, the issue with the soft palate is that it extends caudal beyond the tip of the epiglottis and into the rima glottis, or into the laryngeal lumen, which acts like a cork, causes obstruction of airflow. It is the major cause of obstruction in a lot of clinical cases. So these dogs that you hear snorting and snoring, that issue often is the soft palate. I apologize that we're having streaming issues. There's nothing I can do to fix it right now unless I stop the live stream and then try to restart it, which I don't think would work very well. Anyway, thickening of the soft palate may be breed related or may be due to inflammation or edema from turbulent flow. So again, you can have thickening of the airway, edematous, inflamed from the turbulent airflow. And again, that contributed to the tonsils being enlarged as well. Next issue is laryngeal collapse. Laryngeal collapse is a secondary problem due to negative pressure in the airway. So in dogs, you have these saccules that sit outside of the airway, and I don't know who invented them or what they're there for, but when you have all that negative pressure that you're breathing against your soft palate, your nares, the tonsils, what can happen is that those saccules can pop into the airway like this. The best description I've ever heard of them is when you look down the airway, you see laryngeal cleavage, which is basically these two big soft tissue masses that can fill that airway. And just note that if you have a dog that's kind of percolating along pretty well, with its soft palate issues, and then suddenly it has acute deterioration of its BOAS signs, it could be because the saccules have everted, and so that can cause acute exacerbation. And again, when you're resecting these, what you're going to do is you're going to grab these with some forcip, DeBakey forcip, Ellis tissue forcip, something like that, and then cut that margin right there to cut them out of the airway. All right, so we grade laryngeal collapse. Grade 0 is normal, so that's what a normal larynx should look like. This is what it would look like if you look down the airway of a normal faced dog, like a dolichocephalic dog. This is grade 1 laryngeal collapse, which is where we have the saccules starting to push into the airway. Grade 2 is when you have medial deviation of the cuneiform process. So this is the cuneiform process right here on either side, and these deviate medially. And then grade 3 is when the corniculate processes collapse in. Now, I always struggle to differentiate the cuneiform and the corniculate process, and the way that I remember it is that corniculate means horns, and so if you imagine that you've got two little devil's horns sticking up here, those are the corniculate process, and then these are the cuneiform process. So again, corniculate means horns. All right, the next issue that we have with brachycephalics is tracheal hypoplasia, and that is a primary problem. If we look at the airway diameter between non-brachycephalic, non-bulldog, brachycephalic, and bulldogs, you see that progressively they get smaller and smaller. And there is a significant difference between the size or the diameter of the trachea between non-brachycephalics, non-bulldog brachycephalics, and bulldogs. And this contributes to overall upper airway resistance. The other thing that can happen is that the mucociliary escalator, so you've got this little escalator along the trachea that moves mucus and bacteria and stuff through out the trachea and into the pharynx so that you can swallow it. That mucociliary escalator, those little hairs, in some dogs with tracheal stenosis doesn't work, and so they're prone to pneumonia. And so what we see often with these guys that have the problem with the mucociliary escalator is that you have little brachycephalic dogs that have recurrent pneumonia that happens. And basically, if I see a brachycephalic that develops pneumonia acutely as a 3-month-old or a 4-month-old or something like that, I'm going to be very concerned that that dog is going to have recurrent issues with pneumonia for the rest of its life, and probably is going to have a very shortened lifespan. Now, what about gastroesophageal issues? These dogs almost universally have gastroesophageal reflux. So there was one study that showed that 91% of dogs of brachycephalics have esophageal ulcers, and 98% have signs of gastroesophageal disease. And those signs are going to be things like reflux, regurgitation, vomiting, things like that. And between 7 and 65% of them have hiatal hernias. And just note that symptoms can improve of gastroesophageal disease if you fix the airway obstruction. So what's happening with these guys is when you have the diaphragm moving back and forth like this, you have the upper airway up here. When you're sucking so hard against the airway obstruction, you're creating a huge amount of negative pressure inside that thorax, and as a result, you are sucking stomach acid from the stomach up into the esophagus, and that's causing gastroesophageal ulcers. There's a question here. Do you think performing alloplasty first but not staphylectomy at the same time can increase the airflow and potentially vibrate the soft palate more, worsening the thickening? Ryan, I've never heard of that before. That's an interesting pathophysiology. I do think that most of these guys need both the nares and the soft palate trimmed at the same time at least. And so if you're doing the nares, you really should take a good hard look at that soft palate and decide whether that needs to be removed as well. So looking down here, this is a lateral thoracic radiograph with contrast administered to the esophagus, and we can see a hiatal hernia here, which is where part of the stomach is pooching up through the diaphragm. All right, so there is now a grading system that's been looked at for Brachycephalic Airway Syndrome. Grade 0 is obviously clinically unaffected. Grade 1 is mildly affected, so that's mild noise, but no functional impairment. Grade 2 is moderately affected, which is moderate respiratory noise with some impairment, mild dyspnea, sturdor, or a mild delay after exercise. And then severely affected dogs are grade 3. They have severe respiratory compromise, marked dyspnea, cyanosis, exercise intolerance, and distress or collapse. Now, when we assess this, we want to assess it when they come in, and then after moderate exercise, about 3 minutes of trotting around. Now, if you are already a grade 3 at rest, you don't need to exercise these guys because you know they're going to be a grade 3 afterwards. So definitely, if they're already a grade 3 when they walk in the door, don't take them outside for a trot because you could cause exacerbation or acute exacerbation of clinical signs. So so grade 0, 1, 2, and 3, we want to look at these before and after moderate exercise. So remember, the exercise test is 3-minute trotting test on a lead, and it's not needed if they're already a grade 3 at rest. And we want to look at assessment before and after exercise, including stridor versus sturdor, how much effort they're making breathing, what's the rate of recovery after you stop exercising, looking for signs of distress, gagging, and cyanosis. So what's the evidence? There was a study that was done in 2015 that showed really good correlation between the clinical grade, 0, 1, 2, and 3, and the measured airway resistance. So they actually connected them to a device that measures airway resistance and found that there was a direct correlation between grade and resistance. And grade 2 and 3 dogs had significantly reduced airflow and oxygenation compared to 0 or 1. So it looks like this is a clinically relevant or clinically important diagnostic test. There's another study that showed that dogs with higher grades without surgery had poorer long-term outcomes. So they had a higher chance of heat stroke, syncope, shortened lifespan, and gastrointestinal disease. So high-grade dogs have a poorer long-term outcome. There's a question about can tonsils and soft palate be removed by cautery? And so the answer to that is, with careful and judicious use of cautery, you can remove the tonsils and the soft palate. Remember that whenever you use cautery, you're going to have a thermal burn, thermal spread, meaning that you may just be cauterizing at one point, but you may have significant increases in heat and potentially necrosis up to 5 millimeters away. So just be aware of that. And so, yeah, that is correct, unlike nares. So, yes, you can use judicious use of cautery on your tonsils and your soft palate, but again, you need to be very careful. All right, there was another study that compared pre and post grade of BOAS, but pre and post surgery, and found that there was a significant improvement in grade following brachycephalic airway surgery. And so grade 2 and 3 dogs improved mostly down to grade 1 or 0. So a good surgery, you can really reduce that airway compromise. And that improvement was also correlated with an owner-perceived improvement in quality of life, breathing, and exercise tolerance. So that shows that surgery is effective at improving these guys. All right, there's another study that was done that showed that the higher the pre-op grade, the higher the risk. And so if I have a dog that comes in and it's just snoring at night, maybe a little bit exercise intolerance, I'm much more comfortable proceeding the surgery. Whereas if I have one that comes in already cyanotic, is a solid grade 3 without any activity, I'm really worried about how that dog's going to do a surgery. And so they're more likely to experience post-op complications like prolonged recovery, aspiration pneumonia, post-op dyspnea, respiratory crisis, need for revision surgery, and need for a temporary tracheostomy. So in one study, grade 3 dogs had a 20 to 30% complication rate compared to less than 5% of grade 1 dogs. Okay, so really important to grade these guys. What other diagnostics besides a laryngeal or oral exam and external assessment of the nares and looking at exercise intolerance and things like that, what else can we do? So some people do computed tomography on all of these patients. I usually don't unless I have a patient that doesn't do well with surgery, with the initial surgery. So what's the benefit of doing computed tomography? We can look at the nasal turbinates, the aberrant conchae, we can look at the thickness and the length of the soft palate, we can also look at tracheal diameter. And again, some people say that this is a standard part of their workup. I generally don't unless I have a dog that doesn't do well after an initial surgery. I have another question from Ryan asking, the reason I ask is I usually will perform alloplasty with desexing and assess the soft palate, but many owners are not ready for their dogs to have the soft palate. Should I avoid just doing the nares first? So, really good question. And I'm not seeing these dogs at the time of desexing. I'm seeing them when they have problems later on. If they are already showing problems of upper airway distress with Sturder, Strider, things like that, I think you probably ought to be doing the soft palate at the same time if you're comfortable with doing it. If you're not comfortable with doing it, you certainly can do the nares. Do it at the same time as the desexing. It's not going to hurt anything, and you're unlikely to negatively affect your ability to do something definitive later on. So it just depends on your comfort level. comfortable doing soft palate, do it at the same time. If you're not comfortable with doing soft palate, then just do the nares. Another diagnostic test we can do is fluoroscopy. So fluoroscopy, we can look at dynamic pharyngeal function and potentially assess for a hiatal hernia. So looking up here, we've got a dolichocephalic dog, so a normal nosed dog. We see that nice, thin, soft palate that's going underneath the epiglottis. Compare that with a brachycephalic dog, and you can see this highly thickened soft palate all the way down to here, and that's the epiglottis right there. So it's actually sucked the soft palate into the rima glottidis, and it's no wonder these dogs are having a lot of trouble breathing. All right, what about endoscopy? Other than looking at the larynx, which isn't, I guess it technically is endoscopy, but it's not often what we call endoscopy. It's usually not done at first presentation. Why would we do endoscopy? Well, if we have a dog that doesn't do well with the initial surgery, we might do endoscopy to assess the nasal turbinates. Again, you can look at pharyngeal function, and you can look at the existence of a hiatal hernia. I can't remember the last case that I did a endoscopy for Brachycephalic Airway Syndrome, except for potentially looking down into the esophagus to look for ulceration. I've done that occasionally. All right, what about the Brachycephalic Risk Index? And that was a study done by Brandon et al. In 2019. And what they're looking at as risk factors include breed. Are they an English or French Bulldog? Because those do worse. Have they had a previous surgery on their airway and they're presenting again? Those dogs are going to do worse. Are there any extra airway surgeries planned? Are they planning on doing a desexing? Are they in a severely affected dog, are they planning on doing a total ear canal ablation? Are they planning on doing patellas? Are they planning on doing spinal surgery, something like that? If you have a severely affected dog that has other risk factors and you're also doing another surgery, that can significantly increase the risk of complications. What's the level of compromise at admission? What's the body condition score? So is it a 5 out of 9 or is it a 7 out of 9? And then what's the temperature at admission? And what they find is that you get a bell-shaped curve of brisk score at admission. It's a perfect bell-shaped curve, but what they find is that the higher the brisk score, the more likely you are to have significant complications. Okay, so the higher the brisk score, the more likely, and in fact, brisk scores of 9 or 10, I think, have about 9 to 10 times higher risk of significant complications compared with dogs that are in the 2 to 4 range. All right, so we'll just go back just to reiterate that dogs that have a high brisk score have 9 to 10 times higher risk of a complication than dogs that are in the 2 to 4 range. All right, so what does medical management look like for these guys? I'm not saying you have to do surgery on all of them, although a lot of them would benefit from surgery, but most important thing you can do is weight control in these guys. Either before or after surgery or instead of surgery, weight control is so important in these guys in reducing the risk of clinical BOAS. And that's the same thing they say if a human goes for sleep apnea assessment and surgery, they will tell them lose weight. That's the most important thing that you can do, is to lose weight. We want to moderate exercise, and we're going to avoid overheating and overexertion. We're going to recommend using a harness instead of a neck collar. Keep the patients cool. So owners often will keep the air conditioning on when it's hot outside. We're not going to have them outside when it's hot. We're not going to exercise them when it's hot. Certainly not leave them unsupervised when it's a really hot day. And you can use corticosteroids intermittently for pharyngeal inflammation, but it's certainly not something that you want to leave them on a long-term basis. All right, what about the gastrointestinal issues? So we are going to keep these dogs certainly in the first 2 weeks after surgery on proton pump inhibitors. So that's going to be omeprazole or pantoprazole. And some of these dogs need to be on them for a longer period of time. If they have continued regurgitation, bloody regurgitation, white foam, that kind of thing, we're going to want to keep them on omeprazole long term. Some people use metoclopramide or cisapride, which would be a prokinetics, to help reduce the incidence of regurgitation. And we certainly want to keep them on them perioperatively to manage the esophagitis, reduce the likelihood of regurgitation, and also subsequently reduce the likelihood that we're going to have aspiration pneumonia. All right. Perioperatively, they have found that using a standardized protocol for brachycephalics is going to cut your risk factor of respiratory distress by about 2/3. Okay, so if you don't have a specific protocol, you're going to have a 36% risk of complications, whereas if you use a standardized protocol specific to brachycephalic dogs, you're going to drop that risk down to about 12.8%. You definitely want to consider prokinetics like metoclopramide and acid suppressants like a proton pump inhibitor. You can do it the day before surgery. That's not something I typically do unless I've got a really severely affected dog. It's not proven to reduce regurgitation, but it's easy to implement. They're not expensive medications, and so that might be something to consider. When you're anesthetizing these patients, you definitely want to rapidly induce them. So we're going to use Alfax or propofol, something like that. And then we're going to avoid full agonist opiates like morphine or methadone. I much prefer to use partial agonists like buprenorphine or butorphanol. Avoid full agonists like morphine and methadone. All right, some people consider, and I haven't really done these before, but I am going to start doing them, is bilateral maxillary blocks. So what we're doing with these is you're going in with a needle just below the zygomatic arch, and we're going to block that maxillary nerve directly. So this becomes the infraorbital nerve as it goes through the infraorbital foramen, and it's the maxillary nerve within the orbit, and so you're going to inject bupivacaine or lignocaine surrounding or around that nerve prior to surgery. And so if you want to learn how to do that, scan this QR code or take a screenshot and scan it later, because this is a complete description of how to do this procedure. I think it's by B. Braun or Esculap or something like that. So you're fine coming in. There's a question, do I prefer to use steroids or non-steroidals for inflammation perioperatively? I typically do not use non-steroidals because of the risk of gastroesophageal ulceration, so I try to avoid those. I often will give a single intravenous dose of dexamethasone sodium phosphate at induction to try to reduce the likelihood of inflammation or swelling associated with that surgery. So I prefer a single injection of a rapid-acting steroid rather than non-steroidals. So regarding extubation and recovery, we want to delay extubation for as long as possible. I had a picture, and I can't seem to find it, of a dog that's actually gone for a walk outside after surgery with its tube in. So they love having this oxygen going to their brains and breathing so nicely by having that tube in. And so leave that tube in as long as the dogs will tolerate them. We want to use low-dose sedatives. I really like acepromazine, and I'm going to use a dose around 0.005 milligrams per kilogram. Again, that's 0.005 milligrams per kilogram. We're going to use partial agonist opiates after surgery like butorphanol or buprenorphine, and not full agonists like morphine, oxymorphone, methadone, things like that, because those tend to reduce the respiratory drive, cause respiratory depression, and they also can cause relaxation of the pharynx. We're going to post-oxygenate these guys, so we're going to use flow-by oxygen for as long as you can, and we're going to closely monitor them. And when I was a vet student, we had a breeder that bred English Bulldogs, and when they brought the Bulldog to the clinic for their scheduled cesarean section, they would find the student that was on anesthetics on their patient, and they would give them $100 at the beginning of the surgery, and then give them $100, or they'd tell them that you'll get another $100 when this dog goes home alive and well. And back in 1990, that was a lot of money. And so the prospect of getting a couple $100 was enough to have that student staring at that patient for hours and hours after that procedure. We need to be prepared to re-intubate or to perform an emergency temporary tracheostomy. And so you need to have endotracheal tubes available right next to the patient as it's recovering in the cage, and ideally you should know how to do a temporary tracheostomy. I avoid nonsteroidals on recovery on these guys because I am afraid of the gastroesophageal ulceration. I also discharge these on the same day. So if they're a grade 1 or 2 and they've done well with the surgery and they're recovering well, I'm going to send them home the same day. And the reason why is that I think that they're much less anxious at home, which means they're less likely to be whining and panting, which means they're less likely to have progressive swelling of the airway. And I'm not aware of a problem that I've had with this in the past. There was a study that was done by Grand et al. In 2020, and they showed that in 92 French Bulldogs, all undergoing BOAS surgery, half of them were discharged the same day and half stayed overnight. There was no significant difference in the postoperative complication rates between the groups, and they observed lower stress behaviors at home than in the dogs that were hospitalized overnight. All right, be careful though. Grade 3 dogs, those with grade 3 laryngeal collapse, or even severe grade 2 laryngeal collapse, so that's going to be your cuneiform and your corniculate processes. Those that have severe regurgitation or gastrointestinal complications, those who have a difficult extubation where you extubate them and they're really struggling to breathe and you have to either re-intubate them, or you're just sitting there staring at the dog and they're really struggling to breathe after surgery. Those are definitely ones that should be observed overnight. Some people think that French Bulldogs, particularly those with a history of post-op complications, may benefit from longer observation. In my experience, dogs that are a grade 1 or a grade 2, I am very, very likely to send them home the same day. Same thing with laryngeal paralysis. So if I do a laryngeal tieback on a dog and it's recovered well from the surgery, no evidence of aspiration pneumonia, I'm going to send that dog home the same day. All right, so surgical positioning, there are any number of different ways that you can position them. My favorite is probably to hang the maxilla between 2 IV poles using some gauze. I'll also get a piece of tape and tape the lower jaw down to the table, avoiding the tongue and the endotracheal tube. These are really nice. They're made by IM3. They're actually rodent dentistry brackets, and so they're a pain in the neck to get the dogs into the bracket, but once you get them in there, you get a really good view down the airway. Makes surgery a lot easier. This is another modification where they're hanging the maxilla from 2 IV poles and then they're using a mouth gag to keep the mouth open. Just note that that gag can sometimes get in the way when you're operating. But whatever you do, I like to do them in sternal recumbency because otherwise the tongue falls into the airway and it makes it harder to see. So I prefer sternal recumbency, and I am going to pull the maxilla up and pull the mandible down using this bracket. Now, I'm a little concerned, this is not one of my patients here, I'm a little concerned about the way they've done this, where they've got the bracket over the tongue, because I'm concerned that that's going to cause some congestion and swelling of the tongue. My preference would be to have that lower bracket on the mandible, right behind the lower canines, rather than over the tongue. A question about, do you give trazodone to go home post-op? I'm not opposed to that. You just want to avoid sedating them too much, because if you sedate them, you're going to get respiratory depression, and you're going to lose that drive to breathe. Also, the pharynx can relax a little bit, so I would be concerned again about the amount of sedation that you might get with trazodone. So just be careful with that. All right, so stenotic nares. Let's talk about surgery. So most typically, people are going to use an alar fold wedge resection, and that's what I use almost all the time. So we're going to just take a wedge of tissue out of this alar fold and then we're going to suture those together to open that airway. Now the key thing with this is that you have to make sure that your alar fold goes deep enough, because a lot of these, the obstruction actually is quite far caudal, quite far in from the tip of that nostril. All right, the other thing that I really like to do is use a 50-50 mixture of lignocaine or lidocaine if you're in North America or Europe, and adrenaline. We're going to use a total volume of 1 to 2 mils for both of these, so for both nostrils, and we're going to inject into the dorsal area of the alar fold prior to excision. So what I'm going to do is I'm going to stick that needle in, and then I'm going to inject as I'm pulling the needle out. And what that's going to do is it's going to distribute the adrenaline and lignocaine or lidocaine into that alar fold, and it significantly reduces bleeding and probably pain when you're doing this procedure. I universally do this all the time, and the amount or the difference in blood loss that we're getting with this treatment prior to alar fold resection is really substantial. If you do this right, that alar fold is basically dry and bloodless when you're doing your alar fold resection. Now the other thing that I do is that I put in a stay suture at the apex of where I'm taking my wedge. And so I'm going to take a 4-0 PDS stay suture, get a nice deep bite, and then lift the nostril up. I'm going to have my assistant lift that up while I'm taking my alar fold. And what that does is it allows me to go a lot deeper with my alar fold resection. And then I'm going to use that same stay suture to do a simple continuous suture pattern to suture that up. And by using that stay suture, I'm going to be able to get my last suture much deeper in there. The adrenaline is 1 to 10,000, I think it is. Does that sound right, Cindy? 1 to 10,000 adrenaline? I can't remember. Can you run and grab me a bottle? Yeah. Yeah, we'll grab a bottle and I'll tell you for sure. The other question that I have is, so I have an experience using laser for nares and soft palate. I use laser for soft palate resection regularly. I have not used laser for the nares, and I have a diode laser, and I would just be concerned that my diode laser wouldn't have enough power to cut through the nares. I haven't actually tried it, but that certainly is reported as a potential use of laser. If you have CO2 laser, it's definitely going to have enough power to cut into that nares. All right, the other option for removing stenotic nares that I have done and I've seen a lot of people do is Trader's technique. And what's Trader's technique is where you're amputating that whole alar wing. Generally, it's reserved for severe stenosis or very small nostrils, although I have heard of some surgeons using it in every case. I'm not sure. I think that's probably overkill. You don't get as nice a cosmetic outcome, but look, they're okay and they can breathe really well. It has been shown to significantly improve airflow, but clinically there's no benefit to either procedure as far as clinical outcome is concerned. So it's whatever you're comfortable with. Some people really like the Trader's technique, and I myself like to just use a regular alar fold. All right, so this is a video that's going to show you the Trader's technique. See if I can get that to work. All right, so you can see that with a hemostat, they're parting that, and then they're going to reach way in there and grab onto the alar fold as far caudal as they can. And then they're going to use an 11 blade, and they're just basically going to cut all the way around it. And it seems fairly brutal to me, but I mean, the fact is that they do breathe very well. It's not something that I typically do. They're going back in now, and they're cutting a little bit more of that alar fold. Now, Cindy, my intern, has gotten me adrenaline, so it's 1 to 10,000 or 1 to 1,000. So I'm not sure which one we use normally, the big one or the little one. I think we use the little one.
The little one is no adrenaline.
Noradrenaline. Oh, okay. All right, so adrenaline is 1 to 10,000. The other one was noradrenaline. So just to reiterate, the adrenaline that we use is 1 to 10,000 dilution of adrenaline. Thanks, Cindy. And so with this Trader's technique, what they're doing is then they are just packing it with a large Q-tip. I have also seen people inject adrenaline into these to reduce the bleeding. So that you can see down there how far back the alar fold goes. They're grabbing onto it with a hemostat, and then they're just going to cut all the way around it with an 11 blade. Again, it seems pretty barbaric to me. So Ryan's asking a question, have you seen a dog that had an aloplasty done at another clinic but wasn't deep enough? How would you redo this surgery? So basically, what you would have to do is either repeat the alar reg resection, or you would go ahead and do a Trader's technique, depending on where the obstruction or the residual obstruction seems to be. So that's a lot of bleeding that you see there, and it just seems fairly brutal to me. But again, there are people that do them and that they clinically seem to do quite well. If I were to do this, I definitely would be doing the adrenaline injection. Back to our presentation. I can't find it right now. Here it is. Whoops. So regarding, let's see here, just make sure I'm on the right slide. Okay, so another hint is that I like to ice the soft palate before and after the staphylectomy. And so what do I use? Either frozen glove fingers. I have heard of some people using Super Dupers, which are basically flavored popsicles. Just make sure that you trim off that sharp plastic edge that's at the end, because I think that may cause some laceration or something like that. And just look how terrible that soft palate is, how long that is. Obviously this is a drawing, but it does extend all the way down into that rima glottidus in a lot of patients. So the other alternative would be a folded flap palatoplasty, and some people like using folded flaps on all of their cases. I personally don't. Somebody's saying frozen tampons work well too, so I assume that those are soaked in water and then frozen. So some people like folded flap palatoplasty in all of their cases. The literature suggests that you're going to get similar outcomes regardless of which technique you use, whether you're using a staphylectomy or a folded flap palatoplasty. Prospective randomized studies are lacking. So there's never been a study that's compared prospectively the two procedures as far as outcomes are concerned. When you look into this airway, what you can see is that they basically resected a disc of tissue, partial thickness. So I'll go back to this slide. What you're doing is you're taking out a partial thickness of the soft palate, and then you're going to fold that forward and suture it in a horseshoe shape. So the way that you tell how far you're going to resect is that you're going to take the caudal end of the soft palate, bring it forward as far as you can comfortably, and that's going to be the point at which you're going to resect it. So then you're going to resect a disc of tissue, and a lot of people will use cautery, either monopolar or bipolar, and resect and stop the bleeding. Now there's a comment here. A colleague mentioned that isoflurane is flammable and could cause a fire. So isoflurane is not flammable, to my knowledge. What was the early anesthetic drug that they used to use was, so none of the modern ones are ether. Ether is highly flammable, but none of the modern anesthetic inhalational agents are flammable, so that's not an issue. So what's your opinion on nebulizing with saline, adrenaline, and Pulmicort pre and post-op? I have never done this before. I have used nasal spray, and I'll talk to you about that in a minute. I have used nasal spray in the airway after surgery and have seen a significant improvement in airflow through the nostril. What is your opinion on nebulizing with saline? Okay, that's what I just answered. Some use mannitol swab to pack the soft palate. Just be careful there. I have used mannitol swabs to pack the soft palate, and I will talk to you about that in a minute. Halothane, I don't believe is flammable. I'll just do a little search here. Is halothane flammable? Halothane is non-flammable. Yep, so that's not an issue either. How long can you keep that position with the mouth open? Does it interfere with the anesthetic? It does not. Yeah, so I'm happy. Like, I'm usually pretty quick with these. If these dogs are in that for more than about 20 minutes, I'd be surprised, 20, 25 minutes. I have not seen an issue with that. In contrast, cats, if you keep their mouth stretched open too much, you can get, there's an issue with blindness, I think, that you can get from keeping their mouth open too long. Actually, I'll go back to my search. What condition can cats get from having their mouth open too wide and too long? Well, it's not common. TMJ problems, no, that's not it. Respiratory distress, that's not it. Feline orofacial pain syndrome, no, there's another condition. I think it's blindness that they can get from having their mouth open for too long. Question about dexdomitor. I think dexdomitor is too sedating for use in brachycephalic airway, although you might consider talking to an anesthetist. Yes, it is optic nerve damage. That's exactly right. Yeah, dexdomitor is not something that I typically use. I'd much rather use a partial agonist opiate and then a low dose of acepromazine. All right, lots of good questions. Thanks. I think it might be compression of the maxillary artery. I'm not sure, and that would be the vertical ramus of the mandible. So a lot of good comments. Thank you for that. All right, coming back here. So this is a video of a folded flat palatoplasty. Now this person is very aggressive, and so I have a lot of concerns about the way that this surgery was done. Let me just see. I think that YouTube is going to tell me that I can't open the video because I'm not old enough. Let's just open this up here. I'm just going to move this part into the field, and then I'll start this over. All right, so what they've done here is that they've put sutures at the caudal end of the soft palate, which is great. They're stretching it forward to get an idea of how much they want to resect, and then they're marking that with electric cautery. And then this surgeon is just very, very aggressive with the procedure, and they're just using exclusively electric cautery to cut it, which again I think, look, that's a little bit too traumatic for my taste. Laser I would be more comfortable with, but the thermal injury that you're going to get from electric cautery, I mean, if anybody does this commonly in this fashion, if you could let us know what success you've had, I'd be very interested to see. I mean, it certainly bleeds less, and you can see what you're doing, but I would be worried about the amount of trauma that we're causing, thermal trauma that we're causing with that electric cautery. The other concern that I have with the way that this procedure is being done is that they're using monofilament suture, which is going to be very stiff, like PDS, and then they're tying the knots in the lumen in a simple interrupted pattern in the air or in the mouth. And I would think that those very stiff suture tags that you're getting by doing interrupted sutures or cruciate sutures in the mouth, I think would be really uncomfortable. And so if I were to do this, my preference would be to do a simple continuous, and I would probably try to bury my knots so that we don't have the ends of the suture tags being left in the airway. Again, if anybody has any comments about having done it in this fashion using electric cautery, I'd be very interested. I mean, to their credit, they are certainly opening that airway up, and they are shortening and thinning the soft palate. All right, so we'll go back over here. And another comment that blindness is reported in these patients. So we'll come back over to Keynote. All right, so the more traditional method is to do a staphylectomy, where we're just going to remove a portion of the soft palate. We're going to shorten it. There are 3 different techniques that I've seen done. You can use a laser, which results in decreased hemorrhage. You can use ligature, which is very, very fast, and I used to do them this way, but that there was one study that showed that ligature staphylectomy is associated with a 6 times higher risk of mortality, and so I've stopped doing ligature. Scissor and suture is the traditional method of doing these. It works really well. Basically what you're going to do is you're going to put a stay suture at each end and then one in the middle, and then what I do is I usually cut halfway across, and then I use this stay suture to suture half of the soft palate, and then I'm going to cut it the rest of the way across, and I'm going to use that same suture to finish my suture pattern down here. If you have laser, it's probably the best way to do it. If you don't have laser, then I would recommend scissor and suture rather than using ligature. Question from Stephanie, is it possible to take too much soft palate? I have never seen a patient develop nasopharyngeal reflux or oral nasal reflux from taking too much. We used to take it back to the caudal end of the tonsillar crypt, but now we usually go about halfway back on the tonsillar crypt, and I've heard of some people even going to the cranial end of the tonsillar crypt. I've never heard of reflux, nasal reflux, but I'd be interested if anybody else has any other comments in that regard. All right, so this is our traditional staphylectomy. Again, what they've done here is they have done simple interrupted suture pattern with the knots in the lumen. I'm uncomfortable with this, and I would think that this dog would be uncomfortable with this as well. I'd much rather bury my knot at one end, do a simple continuous suture pattern, and then bury the knot at the other end. All right, what about tonsillectomy? There are some people that are pushing tonsillectomy in every dog, and I disagree with that. Generally, we recommend removal of tonsils only if they're enlarged, and there's no evidence that prophylactic removal makes any difference, and you are just going to increase the morbidity in these patients. There's a question here, what are the margins of soft palate to remove? So usually we talk about going kind of halfway up the tonsillar crypt. So that's the tonsil there, so we're going to go halfway up the tonsillar crypt. Do I have a video of how to do a tonsillectomy? I have one that I did with coblation. There are several different ways that you can do a tonsillectomy. You can use Metzenbaum scissors, but they do bleed a lot. You can use electric cautery, which is an easy way to do it, and basically you just tug the tonsil medially and then just zap it with the electric cautery as you go. You can use ligature, which works very well, very fast, no bleeding, although you do have an issue with equipment costs. Laser is fast, reduced swelling. You have an issue with equipment costs. There's a question about how ligature is associated with higher mortality. There was just a study that was done that compared traditional scissor and suture with laser with ligature staphylectomy, and they found that in their study there was a 6 times higher risk of mortality associated with ligature, and it's probably related to swelling. All right, so just to review tonsillectomy again, you can either use Metzenbaums, higher risk of bleeding. You can use electric cautery, which is faster with less bleeding, but you do have thermal spread, and so you're going to have some pain and morbidity associated with that. You can use ligature. It's very, very fast with no bleeding, but you have issues with equipment costs. This is for tonsillectomy again. Or you can use laser. If you have the equipment, that's what I'd probably use. It's very fast and you have reduced swelling. Soft palate resection, there are videos, Stephanie, on YouTube, I have a couple on there. It's hard to see because you're always trying to video over the surgeon's shoulders. So it's hard to see. There are some people that probably have better videos than I have on YouTube. So just look up on YouTube for staphylectomy. All right, so laser-assisted turbinectomy for aberrant turbinates. Generally, it's only assessed and treated if the conventional surgery and medical techniques are unsuccessful. We diagnose the aberrant turbinates on CT or rhinoscopy. Most surgeons do not include this as part of their treatment because of the high morbidity and potential need for tracheostomy. So I have heard of these dogs really decompensating after the procedure because of the swelling associated with the turbinectomy. This is a video that demonstrates the turbinectomy. Let me just see if I can get that running. Okay, so this is laser-assisted turbinectomy. That's the owner. So this is a CT scan. Sorry, we'll give that just a minute to catch up. So this is a CT scan showing all those aberrant caudal turbinates. And then this is video preoperatively of how thickened those turbinates are. And I could imagine that this is causing a problem. Now they're going in with a diode laser through an operating channel on a scope, and they're basically just removing all of those turbinates. So now you've got a really clear passage through the nasal cavity and into the oropharynx back there. Okay, and I think that in inappropriate patients, it can work very well. I have never done it, I'll be honest. So with the laryngeal, here's another question. If you do a tonsillectomy with electric cautery, do you ligate it with suture or do you leave it as is? I assume you mean do you close it with suture? And yeah, if you've got a big open tonsillar crypt, I would probably try to suture it. Remember that if you're using electric cautery, you're going to have a lot of thermal necrosis in basically burn tissue, and then you're going to be closing over it, so you might want to leave that open caudally a little bit so that it can drain. Everted laryngeal saccules, if they're out, they should be removed, in my opinion, and I think a lot of people would agree with me. If they're sticking out like this, they're definitely causing a problem, and I would trim them out. When you're removing them, you need to tease them out of the crypt where the saccule lies, and then just cut it as close as you can with Metzen bones. Just be really careful not to damage the vocal folds, because if you damage the vocal folds, you could potentially get stricture formation or webbing. All right, what about laryngeal collapse grade 2 and 3? Prevention is best. So this is a terrible, definitely high grade 2. So we've got our saccules out, which makes it a grade 1. We've got our cuneiform processes touching, which makes it a grade 2. And we've got the corniculate processes that are touching and possibly medially deviated. So they have been people that have tried things like laryngeal tiebacks and partial laryngectomy. They have a very high risk of aspiration pneumonia, and this is something that I would not recommend doing. I would recommend resolving all the other issues. So we're going to do the nares, the soft palate, the tonsils, the saccules, weight loss, cool environment, steroids as needed, and then just try to get them through this acute period and see if we can get some of that edema and swelling to go down rather than doing a laryngeal tieback or laryngectomy. Tracheostomy, as in a permanent tracheostomy, is a last resort, but it can resolve clinical signs if the owner is prepared for long-term, lifelong care of the stoma. And I've had a couple of patients that I've done this in. Certainly is not ideal, but it can work in the right patient and the right owner. All right, postoperatively, this is not just for tracheostomies, this is for every patient. We're going to monitor them really closely, and we're going to re-intubate if we need to, and be very, very quick to re-intubate. If I feel like a dog is really struggling with breathing, I'm going to re-intubate it, leave it intubated for half an hour or so, and then try to extubate it again and see if they can get control of their airway. I usually use Dex IV, so dexamethasone IV at induction. I'm going to feed them within 24 hours. I'm going to use omeprazole for at least 10 days. I'm going to use metoclopramide if they are regurgitating. All right, if you have a dog whose gastrointestinal signs persist despite having them on omeprazole, you might consider doing GI endoscopy to look to see if there's something else there. They may do some biopsies. They may culture for Helicobacter or something like that. If you have a dog that the respiratory signs continue despite appropriate surgical repair, you might consider assessment for aberrant turbinates, which is going to be through CT scan or rhinoscopy. There's a medication called oxymetazoline, which is basically just nasal spray. So Afrin, Sudafed nasal spray, things like that. And what it's going to do, it's going to acutely, markedly reduce the congestion and the swelling in those turbinates. So if you have a dog that you're worried about it recovering, this, it's going to last for 12 hours. It's potentially going to really improve the clinical signs until it's completely awake. Some of the swelling's gone down. It's got better control of its airway. Also, we'll use mannitol soaked sponges in the pharynx. Just make sure that you attach a string to it or you attach an instrument to it so you don't forget it in there and have the dog swallow it. All right, so what's the prognosis? Young dogs with moderate clinical signs with no grade 3 laryngeal collapse, so either grade 0, 1, or 2 laryngeal collapse, generally have a very good prognosis, 3% mortality, 97% owner satisfaction. Note that these will not become normal dogs with surgery. These dogs are always going to be abnormal. They're always going to have their weight managed. They're always going to have to have exercise modification. They're always going to have to be kept cool. I mean, when you look at a dog like this, there's so much extra tissue here. If this is going on the outside, imagine what's going on the inside. This is never going to be a normal dog. So to review what we've talked about today, we want to do early assessment and treatment, and that's key to avoiding secondary changes. We're going to use a standardized grading scheme. And so these dogs, if you have a dog that's showing clinical signs of 6 to 8 months of age, I would operate on those dogs, do their nares, do their soft palates early on, so that we're going to help prevent further swelling of the soft palate. We're going to prevent the laryngeal collapse that can happen later on. Just note that some of these dogs will have recurrence of clinical signs, possibly due to progressive swelling. Sometimes that soft palate can get sucked down into the airway and can swell more, and that may require a new or a second resection. Note that sleep apnea and exercise intolerance are not normal for these dogs. Okay? Sleep apnea and exercise tolerance are not normal for these breeds. And so if you have a dog that, an owner that comes and tells you, oh, it's just doing normal breathing for this breed, and it looks like it's having a really hard time, I would recommend surgery. Kazar has noted that they use 1 to 10 meropenem intranasally. I've never heard of that before. And he's saying that it's the same result as for what we mentioned. I've never used that, so I can't comment on it. We want to, in all of these patients, make sure they lose weight, make sure we manage the gastroesophageal ulceration medically, and that we do surgical repair early to try to prevent the secondary changes, and just be prepared to re-intubate or to perform a temporary tracheostomy after surgery. Okay, so that's it for my presentation. I'll stick around for a few minutes to see if you guys have any questions. I hope that the quality of the stream was good, and that the audio was good and the video was good once I started doing the network bonding. What network bonding does is that it combines all of your network sources, including Wi-Fi, Ethernet, and SIM card, all in one to collectively get the bandwidth that you need to stream this. You're very welcome, Steph. Any other comments or questions? I'll stick around for a minute to see. I'm glad to hear that everybody enjoyed it. What I'll do is I'll give you my personal email address, and then if you have questions you can always email me later. So that's my personal email address. Feel free to use it to ask me questions if you have any issues. Henry, my thoughts on folded flat palatoplasty. I did review it extensively in the lecture. You might have joined late. Generally, I think that probably doesn't provide a lot of benefit over traditional techniques unless you've got a really, really thick and soft palate. I think, it's probably, it's not a bad way to do them. It's a little bit more fiddly, takes a little bit longer, so I don't have any issue with people that like folded flat palatoplasties. A question about giving steroid preoperatively, I do. Again, that's dexamethasone sodium phosphate, and I do give it preoperatively. Any other questions or comments? All right, so I will go ahead and wrap up the live stream. Thanks a lot for watching. I do hope to present some more of these in the future. I'm not sure if I'm going to do it in the same format through YOLO Live or if I'll do it directly to YouTube like I normally do. There's a comment here that said, apparently yes, compression of the maxillary artery can cause blindness in cats. So that makes sense. And that usually happens when you're doing pituitary surgery in these cats. I have heard of some, let's see, thanks for the presentation. Just considering regarding feeding after procedure, would you fast for 12 hours post-op and feed soft meatballs? Look, I get mixed review on that. I'm happy to feed them directly after surgery, but if you do have an issue with regurgitation preoperatively, we're probably going to fast them for 12 to 24 hours. I think meatballs would be fine. How often would I prescribe steroids intermittently for inflammation? I don't very often, but if I did have a more severely affected dog that I wasn't comfortable with operating on, I might put it on a short course of steroids, omeprazole, metoclopramide, and then delay surgery for a week or something to try to get some of that inflammation down. Post-op non-cardiogenic pulmonary edema. I haven't seen that. I suppose that would be a possibility with any kind of obstructive or airway obstruction. I can't say that I've seen it. So regarding the adrenaline and lignocaine, I'm going to use between a half and 1 ml total dose for for both nostrils. And that's an equal mixture of lignocaine and 1 to 10,000 adrenaline. And I don't use antiemetics post-op in these guys. I do use omeprazole to reduce the gastric acid production. Any other questions or comments? I'll stay on for a couple more minutes because we are getting so many good comments and such good interaction. So tracheal collapse. So these dogs don't have tracheal collapse. They have tracheal stenosis. So tracheal stenosis is a congenitally narrowed trachea, and you can't help that with intubation. In dogs that have tracheal collapse, however, like Pomeranians, Yorkshire Terriers, yes, you can get them through an acute crisis by intubating. You have to put the tube sometimes quite far down, which would be beyond the level of the collapse, and then do something like a stent to keep that open. Hi, Fabian from Chile. All right, go ahead and wrap it up. Thanks a lot for watching. I really enjoyed giving this, and I also really enjoy all the interaction that we've had during the video. Feel free to contact me via email if you have questions after this, and we will see you again soon. Remember that we are operating full specialist surgery services out of the AEC in Moorabbin.